you.
It's 2 p.m.
Welcome everyone and happy National Midwifery Week. Thank you for joining us for this first session in the Leveraging Midwifery-Led Care to Address Disparities in Equity in Medicaid Virtual Learning Series. As you may know, my name is Jennifer Moore and I serve as the Founding Executive Director at the Institute for Medicaid Innovation. Before we begin today's session, we would like to thank our funder, the Yellow Chair Foundation, for their commitment to advancing important maternal health topics, especially in the Medicaid population. Through their generous and ongoing support, we are able to offer this free virtual learning series. The Institute for Medicaid Innovation is a 501c3 nonprofit, nonpartisan research and policy organization. We provide independent information and analysis that helps to inform Medicaid policy. We work to improve the lives of Medicaid enrollees through the development, implementation, and diffusion of innovative and evidence-based models of care that promote quality, value, equity, and the engagement of individuals, families, and communities. We have teamed up with our colleagues at the Center for Healthcare Strategies to offer this virtual learning series. With me today is Tricia McGinnis, Executive Vice President and Chief Program Officer.
Thank you, Jennifer. The Center for Healthcare Strategies is really excited to partner with the Institute for Medicaid Innovation on this exciting learning opportunity. For those of you who may not be familiar with CHCS, we are a nonprofit policy center working to improve the healthcare for low-income Americans in 3 different areas: delivery system and payment reform, integrated services for complex care populations, and leadership and capacity building. And we're excited to launch this series.
Thank you, Tricia. We also have other members of the IMI and CHCS team with us, including Karen Shea, Chloe Bax, Preeti Kanal, and Dr. Karen George. 2 years ago, the Institute for Medicaid Innovation noticed an increase in the number of inquiries that we were receiving from state Medicaid agencies, Medicaid health plans, and the federal government about high-value, evidence-based maternal models of care that were underutilized in the United States. In response to national and statewide efforts to address growing disparities in maternal mortality and morbidity, Medicaid stakeholders were seeking assistance from us to help guide their efforts. Accordingly, we sought and received funding from the Yellow Chair Foundation to support the first phase of the project, culminating in the release of the landmark report, Improving Maternal Health Access, Coverage, and Outcomes in Medicaid, a resource for state Medicaid agencies and Medicaid managed care organizations. This report, offering a foundational roadmap, will be referenced throughout this learning series and will be incorporated into the required pre-session activities. We also want to take a moment to thank our technical expert panel members and expert contributors identified on this slide, whose guidance and expertise has been critical for this project. The work from phase 1 of this project led us to the realization that there was a need to dive deeper into each of these topics and offer a learning series with light touch technical assistance. This learning series begins to bring together Medicaid stakeholders, including state Medicaid agencies, health plans, and provider groups. With over 300 participants joining us today for this learning opportunity, we have representatives from 48 states, the District of Columbia, and the federal government, all with the shared goal of increasing awareness of midwifery-led care by applying key findings from IMI's report to their national, state, market, or local clinical setting. As part of phase 2 of this project, the 8-session learning virtual series will provide a roadmap for you to explore midwifery-led models of care in Medicaid and potential next steps. National experts will be invited to discuss critical components of this model, with an opportunity for you, as participants, to engage in the discussion. Each session, as you know, will include required pre-session activities to support shared learning, along with supplemental resources and tools. The session topics that are planned are diverse and will integrate relevant policy discussions, such as the changing policy landscape related to COVID-19, midwifery and birth center licensure, Medicaid reimbursement policies, and establishing the business case for midwifery-led care. Underlying all sessions will be a focus on birth equity for the Medicaid population, including how racism and related social determinants of health affect access, coverage, and birth outcomes. We also want to note that this learning series is focused exclusively on CNMs and CMs who practice in hospitals, alongside in freestanding birth centers. However, we recognize that there are other types of midwives in birth settings, such as CPMs and home births. Although the scope of this project is limited to a specific type of midwife in birth settings, we hope the information presented as part of the series will be useful for all. And finally, we also want to acknowledge that other types of non-midwife clinicians, such as family practice physicians, may replicate elements of the midwifery-led model of care in their own practice. Finally, as we begin the learning series together, we would be remiss if we did not mention that we are already planning phase 3 and exploring potential funding opportunities to support this work. Based on requests that we have already received from many of you, we envision this phase of the project to offer a comprehensive learning collaborative consisting of 5 to 10 teams composed of state Medicaid agencies, Medicaid health plans, and provider groups who will receive intensive technical assistance, deeper dive into the topics covered during the learning series, consultation, peer learning, and one-on-one support. The focus will be on collaboration and co-creation, identification and reduction of barriers, and the design and implementation of a pilot initiative. We will definitely share more as more details become available. Now, let's get started with today's session. We are excited to kick off the learning series with 3 national experts who will present on the topic of high-value, evidence-based maternal models of care and birth equity. During today's session, the speakers will provide information relevant to 3 main learning objectives. They include identifying the elements of midwifery-led care in practice settings, as well as associated clinical outcomes, identifying the healthcare structures, economics, and evidence that influence the uptake of midwifery-led care in the U.S., and identifying the interconnectedness between systemic racism, COVID-19, and birth equity. But before we get started with the presentation, my colleague, Chloe Bex, will review a few housekeeping items.
I kept myself on mute. My apologies. Good afternoon, everyone, and welcome to the learning series. I want to review a few details for today's session and some reminders. First of all, today's session will be recorded and archived on the IMI and CHCS websites. Except for meeting presenters, all lines will automatically be placed on mute. During the meeting, the chat feature will be disabled for all participants. To participate in the discussion with the speakers, please use the Q&A feature to submit questions and comments. Participant questions will be consolidated by the session moderator and asked to the presenters during the Q&A session. After the completion of each session, you will receive an email message with a link to complete a short 5-minute evaluation survey. Finally, all session materials and consolidated notes from the Q&A session will be made available to participants on the IMI and CHCS websites 1 to 2 weeks after the presentation date. Now I would like to formally introduce our first speaker for today's session. Dr. Jennifer Moore is an internationally recognized leader in Medicaid and maternal child health. With more than 20 years of experience, her work at the intersection of clinical practice, research, and policy positions her as a thought leader and passionate advocate. This multifaceted emphasis makes her a respected participant in the national dialogue on these and other healthcare topics. As the founding executive director of the Institute for Medicaid Innovation and research professor at the University of Michigan Medical School in the Department of Obstetrics and Gynecology, Dr. Moore focuses her efforts on strategically bringing together payers, clinicians, researchers, and government to design and evaluate innovative approaches to address maternal health issues, such as opioid use during pregnancy, value-based purchasing, disparities, social determinants of health, and maternal mortality and morbidity. Prior to launching IMI, she served in the U.S. Department of Health and Human Services as a senior advisor, leading the Office of Women's Health and Gender Research and the Patient-Centered Outcomes Research Trust Fund at the Agency for Healthcare Research and Quality. Dr. Moore will be presenting an introduction to high-value, evidence-based maternal models of care.
Thank you, Chloe, for the introduction. Let's jump right in. Next slide. Thank you. What do we know about maternal health in the U.S.? Well, we know there are rising rates of maternal and infant mortality and morbidity with significant racial and ethnic disparities. We know healthcare costs are increasing with poorer outcomes. We know that there are increased reports of traumatic patient experiences. We know of workforce shortages are increasing, presenting challenges for network adequacy. And there are rising unmet social needs, implicit bias, and structural racism. Why are these statistics important to Medicaid? Well, with nearly 50% of births in the US covered by Medicaid, with some states as high as 70%, there's an opportunity to improve access to high-value, evidence-based care. Based on our extensive research at the Institute for Medicaid Innovation, we have found that midwifery-led models of care can be an important intervention to address the escalating poor birth outcomes, disparities, and racial inequities in maternity care for the Medicaid population. What do we know about the outcomes from midwifery-led models of care? Well, consistently, studies have found that midwife-led models of care, whether in the hospital or in freestanding birth centers, ensures that individuals receive the right level of care and interventions for their risk level, resulting in overall lower rates of induction of labor, augmentation, C-sections, preterm birth, low birth weight, and NICU admissions. Midwifery-led care has also been shown to improve patient satisfaction scores and reduce liability claims by offering culturally congruent, respectful care that is person-centered. Despite the overwhelming evidence that demonstrates improved outcomes and lower costs, the midwifery-led model of care is underutilized in the US, especially in the Medicaid population. Less than 10% of all births are attended by nurse midwives, and less than 1% of births occur in freestanding birth centers. The numbers are even lower when stratifying the data by payer type. Those who are uninsured or have Medicaid coverage are less likely to have access and coverage to midwifery-led care. And yet, this population has the greatest potential to benefit from this model. The value of midwifery-led care has been widely recognized in achieving higher quality of care, reduced costs, improved satisfaction, and supportive network adequacy. With over 30 years worth of evidence that demonstrates the value of midwifery-led models of care, it is gaining recognition as a gold standard model. For instance, The Lancet, an international medical journal, acknowledged the value of midwife-led care, concluding that midwifery is a vital solution to overcoming the challenges of providing high-quality care. The World Health Organization announced that 2020 would be the year of the nurse and midwife. They recognized that the evidence is clear and the time is now. Midwifery-led care should be the standard of care for all pregnant and birthing people around the world. They have elevated the message to a global level that midwifery-led care is safe, high quality, cost-effective, and evidence-based. The evaluation of the Strong Start initiative for Medicaid enrollees, a 5-year program launched by CMS, found significantly better outcomes for people receiving care in midwifery-led birth centers compared with matched population controls, including a statistically significant decrease in the rates of C-section, preterm births, and low birth weight newborns. Additionally, the evaluation found that midwife-led freestanding birth centers lowered the cost of birth with an average cost savings of $2,010 per dyad in the first year of life. Finally, the focus groups concluded with focus groups with Strong Start participants, and they found that Medicaid enrollees were very satisfied with their experience with midwife-led care in freestanding birth centers. Most recently, the National Academies of Medicine, formerly known as the IOM, conducted a review of studies on birth settings in the US. They found, just like all the other individual and collective studies and evaluations in the US and around the world, that midwifery-led care is safe, high quality, improves outcomes, and results in higher rates of satisfaction amongst pregnant and birthing people. They also concluded that freestanding birth centers are a safe option for low-risk individuals, a statement that is in alignment with the American College of Obstetricians and Gynecologists' 2019 consensus paper, acknowledging that birth centers are a part of the healthcare system in the US and a safe option for low-risk people who are expected to have an uncomplicated birth when there is adherence to AABC standards that require freestanding birth centers to have an established consultation, collaboration, or referral system in place. At the beginning of our work on this topic, the IMI team sought to identify why midwifery-led models of care were not the norm in the US, especially for the Medicaid population, considering the 30 years worth of solid evidence. As part of our evaluation, we found several areas that serve as barriers to implementation that we divided into clinical, research, and policy opportunities. A few highlights include, first, there's a need for the development of a business case. Research supports the improved outcomes associated with this model, but is rarely translated into the return of investment for Medicaid. Second, challenges with Medicaid reimbursement, such as incident to billing, inequitable reimbursement rates, and issues around certification and licensure need to be resolved in many states. And finally, there's an urgent need to listen to pregnant and birthing people who are demanding access and coverage to midwifery-led models of care to ensure that they receive person-centered, respectful, and culturally congruent care. This learning series will cover each of these topics and much more as we bring together national experts, scientific evidence, and personal experiences, along with tools and resources to support your exploration of the midwifery-led model of care for the Medicaid population. You will hear about successes, near misses, and ongoing challenges from state Medicaid agencies, Medicaid health plans, provider groups, clinicians, community-based organizations, and consumer groups. Together, we will learn about what is possible and hopefully spark new efforts. And with that, let's begin with our first guest speaker. I have the pleasure of introducing Dr. Eugene Deklerk. Dr. Deklerk serves as the Professor of Community Health Sciences at the Boston University School of Public Health and Professor on the Faculty of Obstetrics and Gynecology at the Boston University School of Medicine. He has been part of the team that produced 6 reports since 2002 on women's experiences in childbirth entitled Listening to Mothers, and is the founder of the Birth by Numbers website. He is a current member of the Massachusetts Maternal Mortality Review Committee and is a recipient of the Martha May Elliott Award from the American Public Health Association for service to maternal and child health in the US. Please join me in welcoming Dr. Deklerk.
This is where I pause for the applause, I assume. And I just assume
Correct.
from around the country at this point. Thank you. I'm impressed at so many people willing to join a meeting on a Friday afternoon on a holiday weekend. Although I realize in the context of the pandemic, you're probably not sure which day of the week it is anyway. So I'll count that as a plus here. Can we do the next slide? So this is from the National Academies of Medicine report that Jennifer referred to. And it outlines the fact that maternity care is only a piece of a much larger system, and that we need to be considering it not just as what happens in the hospital at the time of birth, but in a much broader context. And that those of us who particularly are working in maternal mortality at the moment really have started to move the focus out from just the hospital to all of the contextual factors that shape the nature of maternity care. And future improvements will come from that. So I have a grand total. Jennifer said I had to summarize the whole maternal and child health system in the United States in 10 minutes. So I may go a little bit quickly here. Next slide, please. So one slide on this. Do we really have a problem in the United States? And the answer is yes. I actually have several hundred slides that do this in more detail. And I'll show you where you can get those if you'd like. But I think this is an important slide. It's maternal mortality compared to similar countries, wealthy countries that have very large populations so that there's some stability in their data. And it illustrates a couple of things. The United States ranks last among those countries. But notice the second line from the bottom. There's a tendency to say this is a function of disparities. And disparities in the United States are profoundly high and inappropriately high. But even if you limited the analysis to the maternal mortality rate for non-Hispanic white mothers, we would still rank last. And that captures the two sides of the problem. We still have the problem with disparities, but at the same time, we have more fundamental problems with the maternity care system in the United States. Next slide, please. So in the time I have, I'm going to talk about just three facts. The what, looking at the allocation of resources or the misallocation of existing resources around maternity care, a little bit on the costs of US maternity care, and a little bit on the who. And in this case, I'm guessing the audience, I'm going to focus on midwives, just a shot in the dark. Next slide, please. So this is from the March of Dimes, and they just put the updated report out last month. And this is what they term maternity care deserts. And the places in red are counties that have no midwife, obstetrician, or hospital or birthing center facilities. And you can see large swaths, over 1,000 counties in the United States have none of these. What's led to this? Next slide, please. Part of it is the aging of the obstetrical population. As you can see, substantial number. Two things that this illustrates two things. One, the growing importance of female obstetricians. As you can see in the younger, there's a strong cohort effect that over time, this will become dominated by female obstetricians. But at the same time, we're talking not about the youngest profession in the world, and research on career patterns in obstetrics show that female obstetricians tend to retire at an earlier age than male obstetricians did, which may be more a function of the overall population retiring at a younger age, but suggests we're going to have some holes going forward. Next slide, please. Another characteristic of our system is a concentration of it, that this just documents the number of, this isn't just hospital mergers, this is health systems mergers as well, and the steady increase in the number of mergers nationally, which can lead to, next slide, please, a greater concentration of births in larger hospitals, except this doesn't actually show that. The increase has been in what they term smaller hospitals, but the smaller hospitals aren't that small. We're not talking 100, we're talking 500 births a year in cases like this. The other major contextual factor around this that we need to consider is, next slide, please, the distribution of insurance. And what really struck me was, if you recall back to the slide Jennifer used on which, what's the distribution of midwives in the country, this sort of parallels it in a negative way, in the sense that the states that have the highest rates of uninsured are also the states that seem to have the smallest proportion of midwives, which suggests, I don't know, thinking about that in a way we need to consider carefully. Next slide, please. So let's talk for a couple minutes about costs, because everybody likes to talk money. It's very hard to get your hands around what the financing of the US maternity care system is, but maybe a couple things to use to illustrate here. We can go to the next slide. This is familiar. The US is far and away the biggest spender overall. This isn't just maternity care, but overall, in terms of healthcare, and the differences are growing. It's not only that we're the highest, but that the differences are getting larger and larger. And you can see the average for other wealthy industrialized country spending on healthcare is about 8.8%, and we're just short of double that amount. You would think we'd get a better bang for the buck, but we don't. Next slide, please. Yet, birth is the second and third leading reasons for hospitalizations in the United States between mothers and their infants. And so we're not talking a minor component of the finances of the US healthcare system. And this has been rising dramatically. Next slide, please. As you can see, this is total charges. It's a more complicated argument, but as to charges versus costs, but you can see the pattern. It's pretty profoundly clear of a rapid rise over time in charges. And that's just on the hospital side. That doesn't account for that. And if you're looking at saying, well, 72,000 doesn't seem too bad, add those 6 zeros to it, and we're talking $72 billion in charges just for hospital care around this. Next slide, please. As was mentioned, a substantial proportion of the births in the United States are funded by Medicaid. In the last year, it was 42.3%, almost 50% by private insurers. The stunning one is 4.2% self-pay, even with the adoption of the Affordable Care Act and provisions in Medicaid and Medicaid expansion to try to ensure that at least all women were covered for birth. We're still talking a significant portion of women who report they paid themselves. And this isn't because they wanted to reject the system. This is because they couldn't get coverage of one type or another. Next slide, please. And of course, this isn't distributed equally throughout different race ethnicity groups. And I'm going to pause on this one for a second because it's got a lot of stuff in it. But if you can see, in terms of Medicaid, it ranges from 66% among non-Hispanic American Indian or Alaskan Native mothers to 24% among non-Hispanic Asian mothers. And stunning differences across these groups that suggest maybe differences in the way that care might be organized and provided. Now, how does this play out in the actual costs of care? Next slide, please. This is total per case payments for maternity care for women with employer-based insurance. Again, there's many different studies about the cost of maternity care, and they use different standards and they use different databases, so it's hard to get a clear look at any one piece of this. But it illustrates that between 2008 and 2015, overall, it stayed about the same. But we're talking the same at about $30,000. Notably, in a 7-country comparison, the cost in the United States for vaginal birth was about 50% higher than the average for the comparison, other industrialized countries that were in the comparison, and the cost of a cesarean birth are about 80% higher overall. Here you can see a slight decline in the cost of vaginal births, a notable increase in the cost of cesarean births. Now that gets manifested in another way, another change, as we have the rules for healthcare being rewritten, health insurance being rewritten on a regular basis. That leads to another problem. Next slide, please. And that is out-of-pocket costs are increasing rapidly. The demands for parents to come up with the balanced part of the payment for maternity care has grown substantially as more insurers structure care in a way, or structure their coverage in a way that protects them, if not the parents that they're dealing with. Okay, finally, who provides care? Next slide. And we'll talk a little bit about midwives, and you may hear a little bit about midwives during the course of this session and subsequent sessions. Next slide. This is the trend over time, and you can see the increase, but it's a slow increase in the proportion of all births attended by midwives at 9.4% in the most recent year. If you limit it to vaginal births, it's 13.8%. The 9.4% is among certified nurse midwives. There's a category in the birth certificate called other midwives, which is essentially certified professional midwives. And they're at about 1.2.
2 minutes, please.
Reflecting the rise in home and, to a smaller extent, birth center births in the United States. Next slide, please. What you see here is the difference in distribution by type of provider. Now, it turns out the CNM and the physician distributions by race ethnicity are pretty similar. But in the case of out-of-hospital births and other midwives, that concentrates much more in the white population, which reflects the smaller proportions of women of color having birth outside the hospital. Next slide. And this is the breakdown by payer. And again, for CNMs and physicians, pretty similar, a little bit higher in the case of self-pay for the CNMs. In the case of, again, largely out-of-hospital births, much greater concentration in self-pay. Now, the question is, what if we had a system that provided more midwives? Would there be a sufficient demand for it? Because that's a key part of any kind of change. Next slide, please. Since you asked, the answer is yes, there would be great demand. This is just from the California Listening to Mothers survey that I was a part of the team that worked on. And on the far left column, what you see is in California, 9% of the respondents had had a birth attended by a midwife. But we asked the question, would you be open to having a midwife in a future birth? And you can see 54% were open to it. 17%, twice as many as actually had one, definitely wanted a midwife. And I think notably in the case of concern with disparities, the lowest proportion of women who had a midwife in California were non-Hispanic Black mothers. And they were the ones who were most interested in being attended to by a midwife in a future birth. Next slide. So if you want something that captures the differences between the United States and other countries, this is a comparison with 9 other industrialized countries. And what it shows is we have a slightly smaller rate of obstetricians per 1,000 births, but we have a fraction, 1/9 as many midwives per 1,000 births as those countries. And so if you think back to that maternity care deserts map, one of the easiest ways to try to fill that in would be to try to have comparable numbers of midwives to our sister nations.
Dr. Deklerk?
Huge amounts of
Dr. Deklerk?
Yeah.
Thank you so much. I'm so sorry to interrupt, but we're going to have to leave it here, and participants will have the opportunity to hear more from Dr. Deklerk during the Q&A section of this session. And now I'm going to have to turn it to Dr. Jennifer Moore, who will introduce our next speaker.
As a reminder to everyone, the slides will be available afterwards, and you also have an opportunity to submit your questions to Dr. Deklerk and our next speaker in the Q&A box. With that, thank you, Dr. Deklerk. We really do appreciate the presentation. There are far more slides than there are time to go through, but certainly everyone will have access to them. At this time, we're delighted to introduce our next speaker, Dr. Joya Creer-Perry. Dr. Creer-Perry serves as the founder and president of the National Birth Equity Collaborative. She's a global maternal health advocate, recently addressing the United Nations Office of the High Commissioner for Human Rights. Previously, she served as the executive director of the Birthing Project, director of Women's and Children's Services at Jefferson Community Healthcare Center, and as the director of clinical services for the City of New Orleans Health Department, where she worked to improve access and availability and affordability to healthcare to New Orleans citizens post-Hurricane Katrina. Her love is her family, health equity is her passion, maternal and child health are her callings. Please join me in welcoming Dr. Creer-Perry.
Thank you so much, Jennifer, and it's hard to act to follow Dr. Deklerk, but I'm going to try. So we're going to talk a little bit about birth equity and how it's important, especially during COVID-19, and for always important for Medicaid and the patients who have that as their resource for insurance for their care. Next slide, please. So our organization is almost 6 years old. And when you focus on Black infant and maternal health, as the data show that has been presented before me, you have to ensure that we have access to coverage for everyone, which includes Medicaid coverage and also includes ensuring that people have the type of services they wish, which is usually midwifery care when it comes to delivery for Black women. And as was mentioned, we don't get a lot of access to it. So hopefully we can think through ways together of how we can improve both the payer's ability to pay for and cover what Black birthing people want to thrive, which is access to midwifery. As an OBGYN, it's important. Next slide, please. So we know that the United States, this slide is really important because it shows that although 87% of our existence in the United States has been under legal oppression, meaning that by law, we could be owned, we could be segregated, we couldn't get access to insurance coverage. That shows that just undoing one law or one policy, or even thinking about the roots of how we created Medicaid and why certain states don't follow through with all of the provisions of Medicaid, is deeply held, not just in policy, but a belief in a hierarchy of human value based upon skin color. So although it's important for us to talk about policy, I just want all of us on this call to think about all the cultural ways that we devalue some of the patients that we see, and how we can undo that through being honest and having truthful conversations about the history and the legacy of the transatlantic slave trade till now on our health in this country and around the globe. Next slide, please. So as was mentioned, I got to present at the UN. The first time I went, they flew me there. This time, a couple of weeks ago, it was through Zoom. So I think I'm owed a flight and a hotel room now, but it's great as a woman and as a Black woman, really going to the UN and seeing how other countries have a human rights framework. Every other country that Dr. Deklerk mentioned that has a better birth outcomes than we do, they operate under a human rights framework. So what that means fundamentally is that you have rights by virtue of being born. If you think about here in the US, so many things, if you think about for Black folks, the civil rights movement, right? It was an attempt to be seen through laws as able to have value and have investment and people to allow you to have freedom. For white women, when they first had birth control in the 1960s, you had to have permission of your husbands in order to buy birth control. So you had to be both married and get permission. So when you have a human rights framework, you don't believe that people need permission or have to be married to get access to birth control. You believe by virtue of them being born, they have full capacity to think and do for themselves. So for us to move forward to really see justice and joy in the United States, we have to move to what every other high income country does and believe that all people have value despite income, gender, race, class, right? It's important for us to move to that. Next slide, please. About 25 years ago, there was a lot of conversation, just like now, about healthcare and policy and elections, right? And so there's a lot of talk about reproductive rights. So reproductive health is what we provide as OBGYNs, as midwives, as nurse practitioners, as doulas, and that's the transactional nature of ensuring that people have pap smears or access to hysterectomies or birth control pills. Reproductive rights are the laws and the policies that dictate how we're able to do those things, or how even people are able to access things like sex education. So for an example of that would be in my own state of Louisiana, where the previous governor passed a law that if you worked at any clinic that performed abortion anywhere, you could not volunteer at your child's school to read a book. So if you worked at a Planned Parenthood, although Planned Parenthood in Louisiana did not perform abortion, you could not volunteer to your kindergarten classes, your daughter's class, to read a book. So the rights and the laws are really, we know, are not under a frame of justice, right? So when you believe in justice, that requires you to have a value that all people have the ability to thrive. So that means you believe that people have the right to personal bodily autonomy. So if they don't want to lark, you shouldn't legislate them to make them have to have a lark if they're in jail or if they don't have as much income, right? That they have personal bodily autonomy in all of those places. To have children, right now, all 3 of my children are here, and I feel like the little old lady who lives in the shoe. But if people want 8 kids, that's their choice to have 8 kids, right? We don't get to dictate how many children people have. To not have children, I'll go back to my own state of Louisiana. Prior to Medicaid expansion, in order to qualify for Medicaid, you had to have been a childbearing adult. So that means you're not valuable to receive health coverage unless you've utilized your uterus to birth a child, right? So people who never choose to have children, they don't deserve to have health insurance, right? So this idea that you're only primaced for birthing. And then this last one, to parent your children in safe and sustainable communities, is so important, because we really need to understand that our reproduction as a Black mother doesn't just end when the baby is born. We worry about outliving our children. So it's important for us to show up, not just for our arguments or our fighting for justice around our reproduction, but also around mass incarceration, police violence. All of that is part of reproductive justice. Next slide, please. So we didn't have a definition for birth equity when we first started 5 years ago, or almost 6 years ago. There were definitions for health equity, for equity in general. A lot of those definitions talk about equity as a place. We're gonna get to this place, hold hands, sing Kumbaya, and everything will be great. We recognize that those who hoard power and wealth today are teaching their grandchildren to hoard power and wealth. So we have to teach our grandchildren to fight for justice and joy. So that means we have to put the assurances, the policies, big P, like Medicaid expansion, like access to postpartum Medicaid for 12 months, like access to midwifery equal pay as OBGYNs. We have to put those kind of policies in place to ensure the conditions for optimal birth for all people. And we have to be willing to address both racial and social inequities in a sustained effort. So a rapid cycle grant or 2 or 3 years is not going to fix it. We're in this for the long haul. Just like that 400-year time frame I showed you, it's going to take all of us believing that we have to continue this for the future for us to get this done. Next slide, please. So what are the root causes of these social determinants of health? Next slide, please. So back in 2005, I was the director of maternal and child health for the City of New Orleans Health Department. And we know what was happening in New Orleans 15 years ago, right? The president flew by and waved at us. But the World Health Organization came to the city, and I was a young person in the room as this young public health person taking notes as they were talking about this new idea that it wasn't your genes or your choices that causes health disparities, but it were things like having safe and affordable housing, quality education, a social safety net. And this was amazing. We weren't blaming and shaming people. We were actually looking at the social determinants. Can you push it again, please? And those things cause psychosocial stress. Push it again, please. And that's what causes a disparity in the distribution of disease, illness,
2 minutes.
well-being. Okay. And so that was really important. Well, you see the top of my slide is still empty. Push it again, please. Because what we haven't talked about is how we get the social determinants. Push it again. And that's a power and wealth imbalance. Push it again. And those are things like our labor markets, our housing policy, our globalization, social safety net. Push it one more time. And that has 3 main root causes, push it again, which are racism, classism, and gender oppression. Push it one more time. So although when you're working on improving outcomes for maternal health and thinking about midwifery, if you don't undo the racism, classism, and gender oppression that makes us not have a midwifery workforce in Medicaid and Black patients not being able to have midwifery care, we're never gonna be able to reach justice and joy. Next slide, please. So the social determinants are these conditions, and they're shaped by resources, money, power, they don't just pop up. Next slide. So it's racism, not race, that causes harm. Although I'm a Black woman sitting here, it's not my skin color that causes us to not have access to midwifery care. Next slide. These are the levels of racism. Next slide. And so granted midwifery, midwives were highly respected and experienced and highly regarded. They operated on African principles of holistic, compassionate, and spiritual care. It began during slavery, but post-slavery, primarily in South and rural areas, they provided care to all people. Black women delivered America for many generations. Next slide. But the erasure of midwifery, historically, they were persecuted and demonized and called witches. Policies and laws were created to inhibit the practice of granted midwifery, and the medicalization of birth pushed granted midwives out as gynecology and obstetrics grew, my field. And the landscape for maternal care for Black birthing people altered to be white male-led, and that's where we are today. Next slide, please. So the benefits of midwifery care have already been explicated by Dr. Deklerk. Next slide, please. Midwifery is relationship-based care. This is my friend, the midwife Ebony, here in DC at a birth center. That's the only FQHC led by a Black woman midwife that has a birth center. It's the type of care that all birth folks need, but especially disenfranchised individuals. It is based in empowerment and support, which is why it aligns with social justice. It is a shame that reimbursement does not match the quality of care that is given. Next slide, please. And that's it.
Perfect timing.
Thank you, Dr. Currier-Perry. Now we want to open it up to questions from the Learning Series participants. As a reminder to everyone, please submit your questions using the Q&A feature. My colleague Preeti Kanal will provide us with our first question. Yeah, she might be on mute. Yep, I'll start. Dr. Deklerk, you were just about to make your final points when your time ran out. We don't want to lose those thoughts that you had. If you don't mind, maybe you can share those final thoughts before we look at the Q&A from the participants.
Sure, I have 130 other slides I'd like to present now, if you don't mind.
You get one.
Oh, okay. No, I mean, the final slides just illustrated that point about countries that do better than us structure their maternity care around midwives, that midwives are the first point of contact for them. And for all of the reasons that have been cited in terms of cost and effectiveness, it makes sense. I did notice one of the questions in the Q&A was about, then why don't we have more in the United States? And that's not a question about the quality of service. That's a question about politics and infrastructure. Actually, the last point I wanted to make in my talk, aside from the fact that if people want any of these slides and a whole bunch of others, they should just go to Birth by the Numbers, is that we keep saying we want to have more midwives. We have to have a real paradigm shift in education, in broadening the number of midwives that we have in the United States, in structuring the system so that it actually works through them. You can't change one part of a system without changing other parts of the system. And I think we need to step back and say, so if we can get the political will to increase the number of midwives, how do we go about doing that? What are the steps that need to be taken? And that starts with educating more midwives. At this point, even if we wanted to put midwives in every one of those counties that doesn't have a provider, we don't have enough midwives to do it. Mm-hmm. And so step one is an education one. And we don't mind spending $8 zillion on more electronic equipment in a hospital, but we balk at the idea of spending anything to improve human resources around maternity care. And I think that's part of just the restructuring of thinking that has to happen.
Thank you, Eugene. Appreciate that. Preeti, hoping you had a chance to unmute your Zoom and we could ask our next question.
Sure. So the next question for Joanne. How can we look at making community-based programs a part of quality of service infrastructure through educational models?
Preeti, it was hard to hear. Maybe you could share it with another colleague and they can ask the question.
Yeah, why don't I go ahead and jump in with this one?
Great, thanks, Karen.
And this is for Dr. Deklerk. What do you think are the main reasons why healthcare systems don't focus on midwives in their network development strategies, despite midwives being less costly and often more effective in terms of patient satisfaction, outcomes, et cetera, than OBGYNs?
Many of those services are actually led by midwives, is the first question, right? We need to have people in positions to make those decisions who are open to midwives as providers. And that's not been the case. By the same token, we talk about the need to diversify the midwifery. By the way, when I was asked what's the one thing we could do to improve midwifery care and outcomes in the United States, my answer was train 2,000 women of color as midwives. Because we spend a lot of time doing implicit bias training, which is fine for existing clinicians, but a greater impact would be achieved by diversifying the pool. And you could diversify the pool of maternity care providers much more quickly through midwifery education. But again, this is a matter of political will. I think there's changes. I think people are more open to it. The implementation is challenging, right? For people who run midwifery programs, you know, they have to find sites for precepting their students. That's not always an easy thing. We have to find funding to cover the costs of education for those who can't cover the costs, which are considerable. And so it's a combination of these things that will start to make a difference. We're at hopefully a break point where people will start making changes like that and make the investment now, because the real results won't be manifested for 5 or 10 years. On the other hand, if we continue to do nothing, they still won't be manifested.
Mm-hmm, mm-hmm. And the questions are coming in fast and furious. So thank you very much. This next question is for Joya. How can midwifery services be used to close gaps in maternal and infant health outcomes? This is more of an operational sort of how-to question.
Yeah, for sure. Well, you know, we already talked about the healthcare deserts that exist. That would be a great opportunity to close some gaps because a lot of those deserts are in urban areas. As I mentioned, my friend Ebony, who is the picture of her with the baby, who's a midwife, she's in a part of DC that doesn't have a hospital, that there's a birth center that is being run by a culturally congruent midwife. who hired a bunch of other culturally congruent midwives to ensure that the community members are seen. But to build on, the truth is we treat midwifery as a luxury in this country. We treat it as something that wealthy people can have, a nice to have instead of a should have. And as long as we treat it as something that's a perk, that's something that you have to be deserved to have, that you can pay cash for, that it's not a part of our current structure for Medicaid or for private insurance, we won't invest in it to be something that we all can have and be seen as. So in order for us to fill the gaps, we need to make it a normalized part of how we provide care for everyone and not have it only specialized to certain groups who are able to pay cash for it. I mean, it's almost treated as if it's like fertility treatments, like it's something that it's kinder and softer and gentler and nicer to people who deserve and who can pay for it.
Mm-hmm. Thank you very much. And this question is perhaps for either Dr. Deklerk or for Dr. Joya. How can we convince state Medicaid agencies to help with spreading the word about midwifery care? State Medicaid agencies sometimes seem a little resistant to move forward. And, how can we be effective in convincing our states to assist in moving this concept forward?
I can go first. I'd like to blame my colleagues in OBGYN. We have a lot of power and we take up a lot of Medicaid dollars. If you think about the current structure of Medicaid, in most states, it's spent on either long-term care facilities and nursing home, and then obstetrical care and neonatal care. So the people who they have to worry about the most are people who are OBGYNs like me. So it's hard to think through, well, what would it look like to invest in a model of care that doesn't cost as much, that is less focused on interventions and technology and having surgeons deliver babies in what's equivalent of an ICU, but having actually care that the patients deserve, that the patients are asking for, I should say, because all of the patients are asking us for lower levels of care, lower technology. They don't want to be in some fancy, it's not the same as doing cataract surgery, right? My father's an ophthalmologist. You need an operating room to open on an eye. You don't need all that. People have been having babies for thousands of years. Anyway, so having Medicaid agencies who are not having to be as responsive to the OBGYN lobbies in their states and who are fighting them to keep their power and keeping out access to having access to for midwives to be able to have their own scope of practice, to be able to open birth centers. So much of it is responding to the powerful lobby of my colleagues.
Yeah, it might be helpful to set up a group. I might call them an Institute for Medicaid Innovation that would start looking at these questions from that perspective. I mean, we need to have people who are in the Medicaid world talking about this. There's a strong tendency. I talk to a lot of childbirth groups and we all talk to each other, and that's fine, but we need to break out of that. And part of it's political. Midwives didn't disappear because they were providing poor care 100 years ago. They disappeared because they weren't organized politically. And so part of it is having people who will do the grunt work of going to meetings with people at Medicaid offices in their states and find out how to get through what is a kind of opaque system of decision-making in most states for their Medicaid offices, and start building the case, the empirical case, not the ideological case, but the empirical case for this. And I think there's more opportunity now than there's been in the past, but it'll only happen if we support people who have those skills, not midwifery skills, lobbying and advocacy skills, who can go in and reach the people who have actual power.
Karen, maybe we have one more question for Dr. Kruger-Perry and Dr. Deklerk before we wrap up our Q&A.
Okay, let me choose the best one here among them all. I think we've got
There's a lot of comments in the QA of agreement to the comments that were just made by Dr. Kruger-Perry.
Right.
Right on, high five, but getting through those, finding the questions.
Right. So what I'm trying to do is to consolidate them so we can help to answer questions, as many as we possibly can. But here's one about education. How can midwives and communities help community education about midwifery care and partner with others and how can people get involved to help women be more aware of their rights and their birth options and women's health care? So it's education not only for the community, but also for providers. And how can we be more effective?
Why don't we give it to Dr. Deklerk, and then Dr. Kruger-Perry, you're going to wrap us up for
Okay,
Q&A. Yep. Finish strong.
Okay.
when I first came to BU is part of their development of a midwifery education program. And the goal of the program was to graduate people who had a CNM MPH. And the people who graduated from that program were incredibly community oriented. And they started a Birth Sisters program in the community. They did all kinds of outreach work. I know it's clinical education is challenging, and you want people who come out of midwifery programs to be really good clinicians. That's essential. But at the same time, in the work that Jennifer cited regarding the Lancet project, one of the things that they concluded was it's not enough, that having midwives in the community is absolutely crucial to serve as the link, particularly for populations that don't trust the hospitals, to have people from the community that have credibility in the community and also have credibility in the hospitals. And midwives are wonderfully positioned to do that, because the fact of the matter is most obstetricians don't want to do community work. They want to be in the hospital. That's how they were trained. That's what their skills are based on. And so positioning midwives to be that link between the community and the facilities is critical. In the Lancet series, we did it in terms of global health. It applies absolutely the same way in the United States.
Thank you. Dr. Kruger-Perry?
Yeah, and I would be remiss if I didn't build on the conversation around granny midwifery and this. To be advocates, we need all of the midwives to agree that we're all valuable. That means that you don't have to be a PhD in nursing in a fancy academic center to be considered a good midwife. And that to lobby together, to organize together, to advocate together means also valuing all the different types of midwifery, investing in some. We've been talking, my colleague Monica McLemore and I talk a lot about investing in HBCUs that have nursing schools to build out that workforce that Dr. Deklerk mentioned. There's a lot of nursing schools there, but there's also people who are interested in doing certified midwifery. So just, we can't, I need midwives, I do, Joya does, who agree that all midwives matter and that it's important to invest in midwives of color. And that's when we will be forceful, because the future is is a diverse future, and having control and only letting certain people be seen as the experts is killing all of us, because we need midwifery to be seen as diverse as the rest of the country is. And so that's the way to the future, for us to have midwifery to advocate for more inclusivity, and for our state Medicaid offices to understand that everybody's deserving of the type and level of care that they desire, which also means that they want people who look like them to care for them and to be midwives in their communities.
Thank you so much.
Great words to wrap up our Q&A. Really appreciate that. Thank you both, Drs. Deklerk and Kruger-Perry, for your informative presentations and really engaging discussion during the Q&A. You've helped kick off this learning series by providing critical foundational information that will certainly inform our future sessions. And of course, thank you to all the participants who submitted questions in the Q&A feature. For those participants whose questions were not asked, please be reassured that we will be collecting all of them and reaching out to our speakers to help provide responses. And we will be releasing an FAQ document that will be shared with all of you within the next couple of weeks. And now, before we close out this session, my colleague Chloe will go over a few reminders.
Thanks, Jennifer. At this time, everyone should have received an email with the link to complete today's brief 5-minute session evaluation. I also put a link to the evaluation in the chat box. If you did not receive the email, please feel free to contact me. My email is on the slide. Our next session is on November 13th, Friday the 13th, and we'll be focused on the value proposition for midwifery-led care in Medicaid. Keep an eye out for the pre-session email that will include the agenda and required pre-session activities. If you haven't already, please remember to add Jennifer Moore's email to your contact list to ensure that the series emails are not sent to spam. Her email is also posted on the slide. Thank you again for your participation, and we look forward to seeing you all in November.
Thank you.
So long.